So I have the great pleasure of introducing our keynote this morning, and I have to go by this paper because this person has accomplished quite a bit. Oh, not the, I've cut some pieces out. Okay. So I'll just read the first chunk. How about that? We'll call that good. Okay. So Kathy Greenlee served for 7 years as the Assistant Secretary for Aging at the U.S. Department of Health and Human Services in Washington, D.C. She was appointed to the position by President Obama and confirmed by the U.S. Senate. During her tenure at Department on Aging, she was responsible for the administration of all aging programs in the nation, including the Older Americans Act funding to states. In 2012, Kathy became administrator of the Administration for Community Living, an agency she created by combining the Administration on Aging, the Office on Disability, and the Administration for Developmental Disabilities. So, let's do that. Please join me in welcoming Kathy Greenlee.
I would add only 2 more things on there because I do appreciate shortening that. I'm a lawyer by training, so I found my way into aging kind of by accident. And I was the Secretary of Aging in Kansas before I went to Washington, so I've got a lot of experience at the state and federal level. I have done hundreds of public presentations, and at this point in my life, I kind of do what I want to do. And I would like to stand down here with you all. Is that okay? Can you see me? I don't like PowerPoints. It's like putting me in a straitjacket. I have notes. We're going to look at my notes, or I'm going to look at my notes. But I would rather stand down here than stand up there. It just feels too far away. But I'm not very tall, so I want to make sure. And I don't want to scare anybody sitting close to me, although I might ask people questions. So let me get kind of set up here. Thank you for inviting me. Some of us went to dinner last night. I grew up in Kansas. I had lived in Washington or in Maryland for 7 years, but Colorado has always been kind of a second home. I have, at this point, a lot of family from here, like the Front Range, Grand Junction. It's nice to come to Colorado. So I'm going to talk. It says I'm going to talk for an hour. Now here's the problem. I can do that. I know enough stuff now that we could talk for an hour. But here's the risk. You'll be numb. We don't want to start that. So I would like to do this a little bit differently this morning. Can I ask you questions as we go? Because if I save 10 minutes at the end, you'll be numb. And it's like, what was I going to ask her 30 minutes ago? There are some things. I told Claire I'm going to ask her a question. I told Jayla I'm going to ask her a question. I would actually like to ask you some questions as we go through this because it is way more interesting for all of us if this feels like a great big workshop than a lecture hall. And that is not as interesting to me either. So I want us to all enjoy an hour rather than just becoming completely numb. So that's my game plan. Now, I've been reading, so John is going to speak next on the panel. How do you say this acronym? SOPCA? I've heard worse ones, really. So SOPCA we can say. So about an effort really that started with Colorado legislature, I think around 2015, a big, complicated, and very involved strategic planning process. John's going to give you all of the details. I read through this. My favorite one, number 6, the healthcare pieces. So I read through all this on my way, on my drive. Then you've got kind of like updates on what we're going to do to make this real. And then the Boulder County Area Agency, as Lindsay just mentioned, and Christine, they've put together their own plan, and you have those out front somewhere. So more planning documents here. You all are very organized. You're doing a lot of planning. And it's very hard, and it's very important. And when I read these documents, not surprisingly, I've been in the field for a long time, I don't really personally learn things that are new, but I do get a different flavor. And it was really interesting to read, for example, in this Boulder County assessment, the per capita income of older people in this county, which is higher than many other counties, but also the attention to people who don't fall in that category, to other people who can be easily overlooked, people of color, people in the mountain regions, LGBT, that we really talk about all older people. So what I appreciate is getting sort of the local flavor when I read a strategic planning document from a community. And thank you, someone wrote it all down. Because I never know where to go find this information. This is what I know, but it's like, I have to go find the research. It's like, can someone tell me, like, how many older people we have, what we're going to have in 2040? And so it's really nice to use this as a research and to keep it and look at it if you're talking about aging, because I don't remember numbers, I remember people and stories. And this is where I go to. So I have seen a lot of these, and I appreciate the work. I could never do it myself. This is not my skill set. I would sort of fall asleep. I mean, I'm not a researcher. I'm not the one, because I asked Lindsay, it's like, did someone write this? I mean, this, we all know what we can do. This is not what I can do. I can read it, but then I'm a different kind of person. Because sometimes when I get finished with this strategic planning, mostly I can easily become overwhelmed and frustrated. And I will give you my best example. It's not even from Colorado. When I was in Washington, I did a lot of work on the issue of elder abuse. That is the work I'm most passionate about. And we helped support some work at the Department of Justice to put together an elder justice roadmap. And it is that. All the smartest people on this topic, all the researchers, they wrote it all down. And then they wrote a roadmap. And here's my favorite one. We need to train all family caregivers in the United States about elder abuse. How? I'm the how person. That it wasn't an implementation document, and I'm an implementation person. So I love reading these, but I have been at the federal and state level in charge of building and running programs. So it's really essential that you take all of these good efforts, at some point figure out what's the how. Because the worst thing that can happen is that it doesn't get implemented and it sits on a shelf. Talk to researchers, they will tell you. Most researchers actually want someone to read their data and implement it. And you have to find a way to make this real. So I'm the transactional person. How do we go about making this real? And I think that there are two things that are necessary if you want to go from sort of this as a strategic planning document to making it real. You have to have a shared vision. I mean, strategic planning is about capturing all this information, but it's about a vision. And there's often, I will tell people, you tell me the vision, I'll tell you the plan. Where are we trying to go? But the other thing is you have to capitalize on opportunity. And this is where the exercise is completely different. So we could get everybody together, read this, come back this afternoon, say, here, what's the top 5 action things that we'd like to do out of either of these documents, the statewide strategic planning or the stuff here in Boulder County. We can say, what are our top 5? We'll list 10, but let's look at the top 5. What will you do if opportunity 6 arrives first? Because you do not control the order that opportunities appear. You have to know where you're going. But action requires 2 things. Either generating the opportunity yourself, you have to agitate sometimes to make an opportunity appear. And you have to capitalize on the opportunities that do. And that's what, as a government official, was always frustrating and why I couldn't do the first part. It's like, tell me the opportunity, tell me the vision, I'll tell you the plan. Because life doesn't work like that. The opportunity, number 1, is workforce. I mean, we're going to talk about where it's in there. Everybody's going to talk. It may not be the first thing that arrives. There may be something else that we can do, and we have to stop and do it first. I created, as we were talking about, Lindsay, in my introduction, the Administration for Community Living, by doing a government reorganization, which is its own exercise in sort of process and frustration and success. And then a federal law passed that made me reorganize a second time, and I wasn't really wanting it to happen, but it happened then, so I had to do it then. So you have to know that things will come along, and you have to take the opportunities where they come. So I want to go through, in addition to just cheerleading for implementation, I want to go through 4 different issues, kind of in a workshop fashion with you all, rather than a lecture. I want to talk about innovation. I'd like to talk about issues that I think unite us, the barriers that we're confronting, and who's going to do this work in the future. Now, I know, because I looked at the booths out front, you come from various places, various professional organizations, disciplines, backgrounds, older people here themselves. I mean, no, we're all coming from different places. But where I would like to start from is actually talking about the Area Agency on Aging. They're the hosts. And talk about that as a fundamental structure. But I do not need to be exclusive at all, but just to think about the Aging Services Network and certainly the Area Agency on Aging as we dive in and talk about innovation. So I mentioned that I have given hundreds and hundreds of public presentations and taken lots of questions. My first presentation as the U.S. Assistant Secretary for Aging, so after I was appointed and confirmed, I went to the National Association of Area Agency on Aging conference in Minneapolis. Where's Sherry? Sherry, were you there? Yep, Sherry was there. I talked about my Aunt Verda. I remember this was my first speech. And I took Q&A, and I'd been on the job for a month at that point. And the first question I got in my first speech was, why don't people pay us for what we know? Which in many ways has framed like the last 10 years of my life. Why don't people pay us? So here I am, fresh new assistant secretary, with a network saying we're not recognized or paid for what we know. And I think this is true. But things are changing. So I would like to talk about the work of area agencies on aging and other community organizations that serve older people by breaking down the work into two categories. There's what we know and the services we provide. They're two different things. There's a skill set in what we know. And then we have things like meals, or support for transportation, or in-home services. But those are two different things. What people were hoping when I became assistant secretary, especially because I'd been administering these programs at the state level, is that I could miraculously make the pot of money grow. The Older Americans Act programs are incredibly underfunded. In 1965, Congress passed Medicare and Medicaid, which are big entitlement programs, and the Older Americans Act, which is not. And that difference, discretionary programs and entitlement programs, sent those programs on completely different trajectories. When I started at the Administration on Aging, Medicare would spend in one day my annual Older Americans Act budget. So they're nowhere close to similar. And if you think about sort of in 1965, Medicare was a health care support. Medicaid currently has become the largest payer for long-term care. The Older Americans Act was always the prevention side. And talk to anybody who does public policy work on any topic. Talk to the advocates for children. The mental health, substance abuse, prevention is always the hardest thing to get funded. So the Older Americans Act was passed. There were some changes in the law. We created area agencies on aging. It started off in good footing, and in the 1980s, President Reagan cut the program budget in half. And it really has never recovered from that severe pruning. So when I went to Washington, and I'm riding on this wave of very competent and frustrated aging services providers, one of the unfortunate things I had to say is, the train full of money will not arrive. There's not a way to magically recover this. I'm very skilled, and I was working for Kathleen Sebelius, who had been the governor that I worked for. This is not going to easily happen. And there are some reasons why it can't. If you wanted to line up all of the programs that are underfunded, do that in your state, do that nationally. We're going to line up all of the unfunded programs. Well, first of all the Medicaid programs are going to be in the list. It's almost impossible at this point to get attention to any one particular program that's underfunded, because Congress and the legislature certainly can't catch them all up. So it's just not realistic. You have provided state funding in Colorado. You must continue to do that effort to supplement with state funds. We've provided state funds in Kansas. They kind of have an interesting trajectory. They go down and sometimes back up. But we can't just easily grow the money for the Meals on Wheels programs or in-home supports. We have to find other innovation. So I want to go back to what we know and the things we provide as different things, and talk about the evolution and opportunity with regard to what we know. So let's start with information and referral. People sort of inside who've been doing this work, Sherry would know this, information referral over the years has becoming increasingly more professionalized. There's a national conference for people who do information referral. Information and referral and the knowledge set of the people who know that is a valuable skill. These are the people you call, which was like, I have no idea how to navigate the system, or who I should call, or where I get benefits, or how I get respite, or who sends. Information referral has become increasingly more skilled over the last several decades. And the people who do that service at a AAA are the ones who started with great big fat notebooks or Rolodexes, who now have electronic resources on where to go. And I often, because I work in this field, have people say, I don't know where to go. Where do I call in Springfield, Missouri? It's like, you call the Area Agency on Aging, because they do information referral. They know how to navigate. And navigation is a skill set. Think about how many other navigators we now have. Sometimes they're called that, patient navigators. They're kind of doing the same thing. One of the key differences is they may be navigating one person at a time rather than a community. Community health workers are navigators. Navigators are our allies. They're extensions of this information referral network that we built. They're the ones. The Promotores program, working with people of Latin or Hispanic heritage, is a navigation program. At the University of Kansas, they have a research grant to work on Alzheimer's disease. They're wanting to build, based on a model out of Minnesota, specialized navigators who can help people put together supports for family members and people living with Alzheimer's disease, sort of like navigation special. Navigation, we now know as a society, is really important. So that's the good news. No one has still figured out how to pay for it. That's the bad news. No one. So are there any others? My question to you. Those are the navigators I could think of. Are there other places that are doing this navigation here? Do you have community health workers here? And how are they paid? You all have solutions on pay? In Kansas City, Kansas, the community health workers are paid by United Healthcare that subsidizes them. I did a talk in Kansas City, Missouri on Tuesday this week, and this woman who came up, who is just passionate about working with older people, she herself seemed to be of Medicare age, talked about doing community health work and how frustrated it was that this valuable thing that we do, this valuable service, is still not paid. So when we think about the knowledge base, I want you to hang on to the fact that the skill set that we have on navigation is valuable, and it's a value still looking for a way to be monetized, that we don't pay for it. It's not the only thing that's our knowledge base when you think about who will pay us for what we know. Area agencies on aging also do assessments and set up services and do case management. We always have. It still surprises people. But we're the ones who not only can get people around, but can take an individual and line up the services and make sure they show up and make sure that it all works. So coordinating care and services is a skill set. It's knowledge. It's what our brains do, and we're very good at it. And there's more hope with regard to coordinating care. This doesn't happen in Colorado, but in other states, when the states started administering Medicaid, home and community-based services, in some states, they contracted with the area agencies to do targeted case management, knowing that the skill set at the community level is something that's valuable and we can help put it together. It is a little more complicated in states that have moved to managed care, which is really not a Colorado problem. But there are issues now about whose job this is. And if it's a managed care company, they want to coordinate the care because that's part of the mechanism of the business model. Who coordinates the care? Who's going to be coordinating the care? Medicare is catching on. Medicare now has the ability of a doctor, a provider, to charge Medicare under Medicare fee-for-service, traditional Medicare, for complex care coordination, complex case management. They can bill for case management. So it's a positive thing when the healthcare system, especially Medicare, which is the big gorilla, right? When they say, we will pay a doctor because this valuable service is now something that we need. And this is an opportunity for the rest of us who do work in the community. Can we now contract with the doctor to say, all right, you're doing care coordination or complex case management, subcontract with us, we'll do that for you. You can do the billing, we'll do the work, we'll report back because we're very good at this. We know how to do it. So Medicare is catching on. Doctors can bill directly. The other kind of changes that are happening, you hear people talking about bundled payments and alternative payment models, sort of the new approaches to how can we just like pay for a chunk of care and good outcomes. Accountable care organizations are another places with enough flexibility that they could also pay for care coordination. Because as the world starts thinking about healthcare differently, it basically is, you all need to kind of organize a bit so that we get the right services in place, and ACOs could pay for this. Again, it has to be a conversation between a community-based organization and a provider to say, don't just build that. Don't just hire a social worker yourself. Hire us, and we can do care coordination. We're very good at doing that. That's another place we get paid. There's a third knowledge base that has a bit of a checkered history now. And Jayla, I'm going to talk to you about this. Where'd you go? I'm going to talk to you about this in a minute. So, how many of you have, over the course of your career working in the field, gotten a call from someone at 5 o'clock on a Friday night because a loved one's going home from the hospital? I mean, they're coming home on Friday at 5. So one of the skill sets and one of the knowledge, well, we know how to scramble at 5 o'clock on Friday. I gave a whole speech up at CMS one time in Baltimore by talking about Jimmy Buffett and his 5 o'clock somewhere. I did a whole speech on that. Because that's us, and it really is. Friday at 5, somewhere in this country this week, they'll call an area and say, I don't know what to do. So it's true that we have an understanding in the community of what's involved when someone's discharged from the hospital. And hospital discharge is getting more attention. And one of the first sort of demonstrations, really was a demonstration project, Jayla, you know where I'm coming now, was a project that CMMI funded, the Innovation Center at Medicare and Medicaid. They decided to fund area agencies on aging and community organizations to partner with hospitals to help with discharge back to community, to do care coordination back to community. And it was hard. It was hard. Because we're really good at scrambling, but planning ahead of time requires getting the electronic health record, problem number one, being able to access it with our own technology, getting enough referral to be able to do the work, and getting ready to staff up. Many of the programs in the communities have been grant-based. Grant-based work goes like this. I'm going to write the grant, and if you fund me, I'll hire someone to do the work. Or you're going to wait until the federal government or the state just sends you your automatic grant. If you're billing a provider, the work is upside down. You have to hire the people and then bill. So when you go from one system to the other, you have to make a financial investment in staff and then hope you have enough work to pay for them. So there were area agencies on aging around the country who signed up because this is promising to partner directly with hospitals on discharge because we know something about this. But it became exceedingly expensive for them to staff up and to get the electronic databases and the interoperable systems that they needed. Technology and staff became a huge problem. So the other part was just sort of a mess at CMS. And like, I'm someone who over the course of my life have decided really I don't need to swear very much, and I don't. But I did with CMS. It's the only meeting I've ever gone to. I'll tell you what I said because it wasn't really, really rough. But I went up to CMS because the A. Jobsons out of Chicago and the Rush Medical Center had a good system with good outcomes, and they got canceled in this program. And I went to their appeal, and then I had the two people who built this program on the side, and they didn't realize that when we built all this interoperable technology, we never included the community. We didn't even include long-term care. We talked about hospitals and doctors. They didn't know these challenges we had, not just the staffing one, but on technology. And what happened in Chicago is they had 7 hospitals sign up. We'll do discharge, we'll send them to you. 1 dropped out. They didn't readjust the base. They assumed that they would do the same amount of work as if hospitals were making referrals, and this is how I swore at CMS. I said, well, hospitals don't give a damn about community organizations. That's how rough I get. But it was hard. There were some places around the country where it was successful, and many places where area agencies just could not make it work. And even though we got the 5 o'clock call, implementing an evidence-based discharge program like the one Eric Coleman here created, I mean, your guy here in Boulder's nationally known for discharge planning. It's expensive and it's hard and it requires different skills. So hospital discharge is still a fertile area for us because hospitals haven't gotten better at figuring out the community. But the first go-round, our first dance with them was kind of ugly. Jayla did that, so I was gonna have you, I told you that I don't wanna just do like 100, whole hour of complete lecture. Will you talk about just what happened here as you were doing it? Jayla with the Denver Regional Council.
I run the AAA in the Denver metro area, which goes all the way to the Eastern Plains and up to Georgetown and over to Castle Rock, and it's a big area. So like a lot of other AAAs in the country, this is a wonderful opportunity. We need to do this. And everything you said was absolutely right. You never anticipate all those things that you have to do. First of all, you have to get all sorts of legal agreements for your people to go into their hospitals. And then your staff have to get shots, lots of shots. Who knew that?
You made me get a shot with you.
I did.
And you publicized it. I got my flu shot with you.
We got shots together. It's all this infrastructure that you don't understand. And then back in those days, because this was, 5 years ago, HIPAA, oh lordy, HIPAA, and how serious HIPAA is. Don't mess with HIPAA. And so you have to sign all these agreements, and you have to get more attorneys to look at your contracts and look at your agreements, and then you go in and do the work, and you realize though you say the same words, they don't mean the same thing. A care conference in a hospital is different than a care conference in the community, and they have different goals. We have fundamentally different goals in the medical system than we do in the community-based system. And trying to figure all of that out. We had, in our program, the 3rd most successful outcomes in the country, and yet we still didn't get re-upped. And we had 13 hospital partners, and I went back to them after we were over, and I said, yeah, we had such great success, right? And those of you hospitals that partnered with us that were on the red list are no longer. Let's do this again. And they said, nope. Loved it when Medicare was paying for it, but they didn't want to pay for it themselves. And I felt so defeated. And I had staff that I had hired and trained, and now it's over, and now what, right? And we got another opportunity just recently to do the same thing 5 years later. And it's called Accountable Health Communities Initiative. It's a demonstration project from CMMI. Some of the problems in CCTP, that's what the first program was called, have been tried to be addressed in this AHC program. We're the bridge organization between clinical providers and community-based providers. And we are including the community connections, that connectivity.
The navigator kind of piece, yeah.
Yeah, connectivity is really important. The challenges are really important. I mean, the challenges are much the same. We say the same language, but they mean different things. But what we're learning is what do you think the #1 Okay, so what we do is we screen people in the hospital and we say, what community needs do you have? Any idea what the top community need would be? I would think transportation too. It's actually food insecurity. 46% of people are saying they don't have enough food. Now this is ridiculous to me. Absolutely ridiculous. This is so easy to fix. Now, trying to get people food is way harder than you would think. I said, let's just take this food into the hospital, like our shelf-stable food, our Blizzard boxes, and we'll send them home at least with some, and then we'll sign them up to these programs, right? And the hospital's like, well, we need an acquisition person. We have to find a place to store it, and then we have to assign someone else to do it. And I'm like, seriously? I'm going to put my car out in the parking lot with a sign that says food here because it's so hard to get some basic stuff done. They're ongoing challenges.
Thank you, Jada. So you've been trying this here, and the reason why I wanted to spend a little time on discharge is we can't give up on this. Our first go-round, our first dance, like I talked about, had some big struggles. The other thing that was clear is we're just really small, and Medicare's really big. And even though you said you were the third most successful in the country, so we go up to Medicare and say, you do this, we can save you $5 a day for your beneficiary. And then someone else down the road comes in and said, we've got an innovative model that'll save you $100 a day. The part of the challenge is doing enough work to be able to see it when you do the math because the program is so big. But discharge planning is not going away. We all will need to partner with the healthcare system, or those of you in the healthcare system. Hospitals are being dinged if people are discharged and they come back within 30 days. They need community partners. The Centers for Medicare and Medicaid just issued new regulations about hospital discharge planning. I commissioned a report on this like 12 years ago when I was secretary in Kansas about discharge planning. I read the report, and here's what I remember. That's a mess. Hospital discharge planning is not a discipline, it's a process. And it is different in every single system. The credentials of the people who do it are different in every single system. The skill levels are, of course, different in every single system. So CMS has new regulations on discharge planning. We need to be focused on the goals of the patient. We need to include the family. And we need to have goals of care when the person goes home. So we have to stay at the conversation. There also, and this would be really too wonky that your brains will fuzz if I go too far down this path, but when someone's discharged from the hospital and they've been there for 3 days on Medicare, you have different options on where you can go for your rehab. And sometimes it's not quite clear why you go to which one of those 4 places, home health or hospital inpatient. And each of those 4 places do a different kind of evaluation once you get there and what you need. That's not what the future will look like because of a change in federal law. At some point, after we get really better at discharge planning, the hospital will have to assess, here's what you need, here's where you should go. And the future will be bundled payments, where we'll say, you came in for a hip fracture, you need some inpatient rehab, this is how much we'll pay for that. So all of these little changes that you hear about sort of in the wind about changing how we pay for healthcare is going to happen at some point for people who leave the hospital. So we have to stay in the conversation about discharge planning. Okay, so do you remember where we've been? There's things we know, how to navigate, case management, something about discharge planning, but we got to stay at it. And then there's the things that we have. This is where we really need more money. I love community health workers. There's people who sort of see the light on community health workers. We've discovered this is really valuable. It's like, yes. And those are the people, the community health workers, are the ones who can now also tell you where we have waiting lists for services. Because even if we found a way to pay for this really valuable skill of navigating all of this complex world, we still have to fund the stuff the people need. The ramp, the meals, the transportation, and we have to find a way to pay for things. So I went up CMS, I used to describe them as my frenemy. It kind of depended on the day or the hour where they were friend or enemy. And I went up when their innovation center started, and I went up to meet the new director who came from a big, sophisticated health system in the Northeast. And I went to tell him, I'm Kathy Greenlee, and this is the Older Americans Act. And I described to him this network of what we provide. The structure that we have area agencies covering every place in the country. We provide home-delivered meals, transportation assistance, support for family caregivers, health prevention programs. We'll bring in-home services in. We'll do all this. He had his computer up for the first 20 minutes, so I thought maybe he was blowing me off, which, of course, would not make me happy. So he's sitting there, and like light bulb went on for him. 20 minutes, he said, oh, there's a law behind you? Yes. Oh, you're those free people. He really said that. It's like, well, there's a law behind us and we're not free. But he said, because he was a doctor, he said, what I used to do is I would see a patient and then I would say to my nurse or my social worker, now I need you to go set this person up with those free community services. Never understanding who paid for them. This is how big the gulf can be when we're starting now to work across the fields of community back to healthcare systems. They actually don't know what we do in community and how it's funded. And the Innovation Center at CMMI at some point recognized that. And so to me, this is how their investments looked sometimes. It's like, we're gonna fund this, and then we're gonna go into the community, and we're gonna fund this, and then we're gonna reach into the community. And so they would have random investments that would reach into the community with no organizing concept of what the community is and how all of us have to work together and how things are funded. There's a wonderful program that they funded out of Johns Hopkins called the Capable Program. And when I first saw it, I thought, well, yes, it makes complete sense, this will work. And here, I know the woman who designed it. I told her, it's like, Sarah, I always think of this as the nurses with hammers. Because it's like, and we have nurses and hammers in the area agency. So what they did is they developed, and CMS invested in this, they developed a model where a nurse will go to someone's home. Well, there's key number one, you gotta get to someone's home. They'll do an assessment, and then they'll set up occupational therapy and a handyman or handy worker to come fix the house so it works for the older person, and they can show that those will give them good outcomes. Is anybody surprised by that? It's like, okay, good. Nurses with hammers, we have got hammers. We've got all of these things. But what Johns Hopkins now demonstrated is the same problem that we all know about. It's not a funded program. This is a type of care coordination. It's limited to those services, and it still struggles to be funded. Are you funding Capable? Bless you. It's something that you should look at. Here, I mean, it's got good outcomes. I did an event in Scranton, Pennsylvania this summer where we had someone from Capable come describe it. Here's the next riddle after funding it is, I don't know how it will work in rural communities because it's very dependent upon 10 visits to someone's home. Well, if they're 3 hours away, you can't drive out there 10 times. So there's some more innovation that's needed, but it's an example of how things are starting to change. With regard to paying for services. So there's another kind of phrase that's become really popular, social determinants of health. Do you feel like saying welcome? Welcome. Social determinants of health. So, and you can show, there's different charts that people have put together to describe just what we're talking about, like life, like where they live, their house, their community, transportation, the water. I mean, it includes everything. Social determinants are everything else that in your world is impacting your health. And if you pull up one of these charts or one of these definitions, what you will find is a smattering of the things that we've always funded through the Older Americans Act. So we should be in the conversation about social determinants. But what I'm curious about is, like, which ones? There's like 30. I mean, if you were going to list, we could get a chart and list them all. We'd all kind of go on for an hour. Which ones will be the ones that will cut through and become the bundle? I agree with you, Jayla. Food insecurity is most likely to be one of those. I was talking to Claire. There's some changes in the Medicare program where they can do a little bit more to support people. And some modest home modification might be in there. Home modification is its own weird policy fight. There's this people who think if you put a wheelchair ramp in front of your house, it makes it more valuable, not less valuable. And so you have to kind of argue and say, we need to make some adaptive changes to a house so it works for people, and it's not about just like increasing the market value. So there are some changes. Medicaid has always been really flexible about supporting these kinds of services. They will pay for transportation. Medicaid, Medicare is likely to do more of this in the future. The Medicare Advantage, so the managed care organizations. You were talking, John, right, about silver sneakers. So Medicare Advantage, which is the managed care product, for a long time has funded silver sneakers. The rules for them is you have to pay for regular Medicare and other stuff if it relates to health. And the silver sneakers program has been very popular. And that other stuff list is what's gotten broader, so that the definition of what those health supports are can be different. And why that's relevant here is any of those kinds of things that we provide, a Medicare Advantage plan now will be able to pay for. But will they? This is the dinner conversation I set by Claire. It's going to hear me, Claire, this afternoon. Will they? So remember where we started on the strategic planning? That you have to kind of sometimes create opportunities and then seize them. Sometimes you can just seize them. Someone else has created them. The reason why Medicare Advantage will pay for a few more of these things now is that advocates worked very hard and changed the law. So they created the opportunity by changing the law. Herculean to change a law in Congress. The second piece is to capitalize on it. It will not flow automatically. They won't just show up and say, anybody build something for us? It won't happen that way. It'll be about us going to the insurance companies that are running these plans and saying, here's our value, here's the things we've always built or provided. Let's provide them to the people that are your members. So there are some opportunities. And Jayla mentioned accountable health communities. In this fuzzy world of changing like how we're paying for things, any of these systems of providers can also contract for some of these things. Meals are always the ones with the most cachet. It's intuitive. You don't have to kind of argue hard for why feeding people impacts their health. Sometimes you have to argue hard on like why not having dental benefits is a problem, but feeding people is something that's intuitive. So there are opportunities that sort of draw upon the base that we've invested in for more than 50 years in these services. But back to the person who asked me the question, why won't someone pay us for what we know? What I have tried to do back to all of the area agencies and all of the aging services is to sort of reflect back on them, I think, their own true value. Because I don't think we ever really thought about what we know. We thought more about what we did, those things we provide. And I don't think that we've understood how navigation and case management is a skill set. And we're very good at it. And we will be able to compete with anybody else who comes to market to do those things because we work directly with older people and we have for a long, long time. So I think there are issues that unite us because people working with, well, older people, we don't own older people in the aging network. Like, older people are showing up in every service delivery system everywhere. And like Jayla said, you've got really different fields of people trying to work together. I did a presentation once with a woman who was the head of the National Visiting Nurses Association. And she spoke and then I spoke, and I had this like light bulb. I'm a visual person, and I had this visual image of me leading the aging network and her leading the visiting nurses. And I said, I feel like we're standing on the same old person's front porch, both looking in, saying, how can we help? And we've never talked to each other, which is true. So having these conversations is actually harder than you would think. But I think in this sort of world of, what are we talking about? There are some common phrases and some common language. Social determinants is going to be kind of funny because I think we can all come to the table with a general sense of, yeah, I know what they are. I don't know if what you know what they are. So we have to narrow down the list. But the other one is chronic disease. that we have more conversations just about the burden of living with chronic disease, and certainly people with multiple chronic disease. And we have invested in, for almost 20 years now, evidence-based programs that we can deliver in a community setting that will help someone manage their depression. They can manage diabetes, other chronic conditions. We can prove the outcomes of this. We know about chronic disease, and more healthcare providers are paying attention to chronic disease. You don't have to explain the term, chronic disease. People get it. Chronic disease is also going to stay really far up front because it's expensive. And people with chronic disease, when you get the numbers people out, will say, look at Medicare spending a lot on chronic disease. So is Medicaid. So are commercial health plans. So chronic disease is a place if you want to find opportunities. What can we do? We've got some evidence, and there really are programs that can help kind of make things better. They're all largely built on the work of Kate Lorig at Stanford, which is about really self-actualizing people, getting them invested in their own health and giving them tools on how they can make things better and goals, and we can prove this. The hard part in that conversation is not the common language. It's finding a way to take these good things we know how to do and scale them. Finding people who will invest, because we know how to make things better. And there's a group called the Evidence-Based Leadership Council. They named themselves in the elevator on the way to see me. So we didn't know what to call ourselves, so we were coming to see you, so we call ourselves the Evidence-Based Leadership Council. You can look for them online. And they're the ones who have really taken Dr. Lorig's work and implemented all across the country different kinds of models to help people with chronic diseases or chronic conditions, behavioral health issues. They've got them all listed on the Evidence-Based Leadership Council website. You need to sort of take those, and if you know how to do those, go talk to your partners from the healthcare side about chronic conditions, because they'll understand the word, and say, here's how we can help. You have to pay a licensing fee and learn how to do the work, but this is an opportunity between us. Another place that I think of a bit as the new kid on the block, this is sort of my favorite after social determinants, is function. And we've always known this in the aging field. In 2015, I think it was, I got to do really cool stuff when I was assistant secretary. I got to go to Geneva several times, work with the World Health Organization. So the World Health Organization came to town, their Secretary General came to town, the director of their aging programs came to Washington. We went to PAHO, the Pan American Health Organization, and we unveiled their report on healthy aging. And the seminal piece, the new finding, Dr. John Beard, who's a geriatrician who was leading the effort, that the seminal finding was that function is essential to older people's health. So, we knew that. And you do need people to research it at some point. This is a complete aside. Years ago, I worked at a battered women's shelter. And I went to a lecture where someone said, who'd researched it, we've researched this and figured out that domestic violence is bad for women's health. Breaking news. But you do need the study and the endeavor and ability to say it really is about function. So when I put that second after chronicity or chronic diseases because you need to combine them. Because the money people, when they look at why are we spending so much on Medicare and who are those people? It's people with chronic conditions, especially multiple chronic conditions, who have functional impairments and functional limitations, who need help with what we think of as the activities of daily living, your physical ability to get around, take care of yourself, instrumental activities of daily living. You all, if you do this, you know what these are. These are sort of skill sets that you need. Can you grocery shop, manage your food? Can you make a meal? I once heard someone describe instrumental activities of daily living as the skill sets you need to get out of your parents' basement. Can you make life work? It's not just can you get yourself to the bathroom, but can you get a job and hold down money and But those and really I was meeting with a researcher up in Iowa a year and a half ago, and had another light bulb. The eye ideals really start to indicate, those impairments really start to indicate some cognitive decline or change. And the activities of daily living are much more about physical function. But function is on the rise because Medicare is paying attention, and the World Health Organization is talking about function, and we've got just more attention to what it will take to help older people remain independent and support their function. So this is a hugely important sort of advancement. WHO, the World Health Organization, talks about two kinds of function. Extrinsic function. Can you get around the world? So the report, you based a report based on AARP's livable communities, and many of the domains in that are about this external world. Okay, I can't get across the street because the crosswalk's not long enough, and we need ramps, and I need someplace to sit while I'm waiting for my medicine. There's a physical world environment of function. We have to help older people by making the external place work, including their home, and they have to have the intrinsic ability to be able to function themselves. So do that, chase that. There's really gold there as we start talking about what we can do to support function. The next issue that I think brings us all together is falls and fall prevention. Now, one of my many pet peeves with Medicare, and that's not a short list, is that they will pay for scooters but not fall prevention programs. That you know, when we go sort of turn on the light bulbs with everybody about function, we then need to move to, we have to assess people for risk of falls. And falls to me is almost as salient as hunger, because humans fall, we all fall. And so people get the danger, and Katharine Graham, who owned the Washington Post, died from a fall. She fell and hit her head. You know, falls can be devastating. All of us know personally or know of older people who fall and break a hip, and this becomes the cascade downward. And it can be a very painful cascade downward. So falls is another area where, when I was working at HHS, I felt like, on the good news side, people got it. The Centers for Disease Control gets it, Medicare and Medicaid get it, everybody gets it. But the key to collaboration is to do something, and that's what's still missing. What do we all need to do together about falls? Because it will not be hard. You don't have to do a lot of definition. Falling, people know. But what should we do together? The Senate Aging Committee just had a hearing on this last month. They have a report that they issued. Senator Collins from Maine is the head of that committee. And they really address some of the evidence-based programs about falling. Fear of falling is also its own risk. And with regard to Medicare, when someone signs up for Medicare, on the Welcome to Medicare visit, the doctor can be reimbursed in the context of that visit for a fall screening and during the annual visit. But there's not otherwise a billing code. Talking about needing to create opportunities that we can capitalize on, this is one. This should be on the great big federal to-do list. We need to make sure a doctor can get paid to pay attention to the older person's risk for falls, outside of just a wellness visit, but watching. We need to train people. I've read and seen about innovative programs where, to do this, they simply go get the person in the reception room, and while they're walking, they pay attention to how the person's getting up and moving. That this is really something we need to pay more attention to. And then I put something on the issues we have in common list because it's a bit of one that I like the most. It's Kathy's rose-colored list. I do think polypharmacy is an issue we have in common. I mean, I do think we know older people take a lot of medicine. You can look at the directions from the American Geriatric Society about which of those medicines become really harmful, the drug interaction. I'm not naive. I think we'll have to tackle falls first, and of course they're related. All of these things are related. Policy pharmacy is related to dementia and falling and function and all this other stuff. You can't separate them. But just like with falls, I don't know yet what we do together. And we will have to wade through some turf. And I saw this happen in Kansas City because the people who should list all the drugs and pay attention to them are really clinicians. But we're the ones who can get into someone's home and open the medicine cabinet. And so how do we find a way to partner in a way where we can be and present ourselves to clinicians as extenders of their work, not competitors, to say, yeah, are you sending anybody to Mary's home? Because I can, and I can use an evidence-based program called Home Meds. It's on the Evidence-Based Leadership Council list. And I'll just run all of those meds through the list, and if anything scary pops up, we'll bring it back to you. And then you'll know what you should bring the person in or kind of further review their medications. I do think polypharmacy at some point is something we have to promote together. And I think this is because I'm a Kansas girl. I always carry a torch for community pharmacists. I've always believed that in our network of allies who work with older people, that we don't do enough with pharmacists. They can see a lot and know a lot, and how do we bring them to the table? And I think for older people, in a world that's very complicated with regard to healthcare, sometimes, and I come from a small town, sometimes those are long-standing relationships, trusted, even if they're new relationships, trusted brokers in some way for older people. No one thinks their pharmacist is going to screw them over. I mean, people really trust their pharmacists. So I think polypharmacy is the other one. So we should think of others. I mean, those are the ones that I thought of on my way out here. Do you have other ones that you think really bring us together?
Hello?
I can't hear you. Just say.
Alzheimer's. Oh. Thank you. Would you consider Alzheimer's under chronic disease, or is that its own little space in the aging
So
space?
remember on my introduction when I said I'm a lawyer? It's always been puzzling because I'll go to workshops in aging where they're talking about mental health, and one of the panelists will talk about Alzheimer's disease, which never crosses my mind. I think of it as like deadly organic brain disease, not schizophrenia. I mean, I always think of it, but some people seem to include Alzheimer's disease with behavioral health or mental health. Other people see it differently. So I don't know kind of where it fits just in terms of the clinical world. It is the only disease state that I typically talk about by itself. I don't talk about cancer, I don't talk about MS, I talk about Alzheimer's disease because the numbers are so bad. We need to continue to focus on looking for a cure, but helping people right now. And so I think Alzheimer's disease can be also, in terms of a particular kind of disease, a unifying issue, and certainly someplace where we can and should really do well by family caregivers and bring them in. But I mentioned the KU Alzheimer's Center. There's a woman there, Michelle Needens, who used to work at the Alzheimer's Association. Oh, I sat in the car and talked to her on the phone, and I'll never forget it. She said people in rural areas with Alzheimer's disease are not treated well with regard to their medications. That many people in rural areas are over-medicated. That the behaviors that can come, or even depression, get missed. And so we could just do Alzheimer's disease and do a lot and find a way to come together. So I talked about like Kathy's internal battles at HHS. And some of it is embracing the need to research for a cure. No one will oppose that, but we cannot overlook services right now to people who are living with it. I have a whole nother sort of talk I give where I talk about to older people themselves like what they need to do, what you all need to do, all of us need to do, is advocate for aging as an older person. And the pace, to me, of greatest hope is the number of people living with Alzheimer's disease who are now coming out and advocating for self. And it's the Pat Summits and the Glenn Campbell and my former congressman in Kansas City who are coming out and saying, I have this. And I think the more we can support older people with Alzheimer's disease advocating for themselves and their families, it will help this issue. Someone here had a question. Yes?
So,
Yep, we're going to get a mic.
I'm Leslie Mader, and I work with True PACE program of all-inclusive
Yes.
care for the elderly. I've been with them for 3.5 years, and everything you've been speaking about, we do. It's
Yes.
holistic.
Yes.
It's awesome. We do preventative. We work with polypharmacy. We keep people socially engaged. So I guess my question is, what is going on in the federal? My major concern is that you have to be low income to be a part of this program, and everyone would benefit from having this kinds of interventions and care in their lives. And I don't know what people in the government are thinking about it, if they're even thinking that it might be something that people who sorry,
Yeah, you've got
that have
got the
assets could actually, for me, it's just a model that just makes sense.
And you have a booth out there. I noticed
I do
that
have
you
a
were
booth
that
out
you're here because PACE, the Program for All-Inclusive Care for the Elderly, which is, that's hard to describe it quickly, but it's just
basically-
complete.
yeah.
It's like a complete closed network that will provide for older people everything from their hospitalization to adult day services to long-term care services, and they do all of those issues are PACE issues. The way it's funded is it's a three-way contract between the provider, Medicare, and Medicaid. So your question was, will it always be for people who are low income as it's structured now because of the role of Medicaid? It will be. The conversations that I was part of kind of on the periphery in Washington was, how do we make this work in rural areas where you really need networks? Can be a challenge. Some question about whether the age should be lowered. To make PACE available to non-Medicaid people, it would take innovation and an approach that allowed people to buy in to Medicaid. That Medicaid rate that's built in needs to be paid by someone. And if it's not the state of Colorado, it will need to be someone individual who says, this is so good for me, I'd rather pay in here. So I don't know, but that's what it would take. Carol's sneaking up behind you. Okay, so I've got 5 more minutes. Is your brain numb? I got 15 more minutes? Okay, I don't want to put them to sleep because they got a long day. But I got a few more things. Here's what I think the barriers are, and they're not going to be surprising because I've already mentioned them. One is just building these relationships and having conversations with people who are very different. When I moved to Kansas City after I left Washington, we convened a group of stakeholders to start talking about these kinds of things. How can we better connect our community organizations with our hospitals, our health insurance companies? And I witnessed firsthand someone get really turfy about who does case management. I mean, we had a nerve because this person was an insurance person, felt like case management was a clinical role. So we have to talk about case management, care coordination. These are kind of the same. And Kansas City almost started down the weirdest path. It's like, I know, we'll just take this thing, we'll name it something else. It's like, you can't do that. You can't have Kansas City's answer that no one in the world will understand, because when it works, you'll spend all of your time explaining that it's really case management. So you have to find a way to call it maybe community, you can modify it, community case management. But part of the challenge now is simply the language. And anybody who's tried this will tell you it's tedious and it takes a long time. So language. You cannot dodge the financing issues. And back to what I said about sort of places where I ran into trouble, we're not the free people. That the people who haven't grown up and done their lives and work in a community really don't know how those services are funded. And that in the community, we need to be comprehensive. There are people who can pay privately and should in community to help the payer mix work. But the healthcare system is great big, and the community system is very tiny. So at some point, the conversation has to be, you have to pay for it, healthcare system. You cannot at some point avoid that very uncomfortable fact that it's theirs to buy. And to get there, it's going to take a lot of coordination, and it takes us from the community side showing up with the goods and the outcomes. And it's the outcomes where we have been historically behind but are catching up to say we can improve health, we can prove it. And when you do that, they will listen, but then you have to have the money conversation. When some states started to take their Medicaid program for older people and use managed care, what managed care did is they signed everybody up for Meals on Wheels for free. It's like, I have a waiting list for Meals on Wheels. You can't, health insurance company, get these things for free. They're not free. You're going to buy them. We'll sell them. We can sell them to you at a good rate because you could probably buy good volume. But these things are not free. You cannot avoid financing, and it's naive to think that you can. Infrastructure is also a huge enemy. That we did not, for anybody in community, we didn't really buy you the technology that you needed. They did in Massachusetts, but really nowhere else. We didn't buy the technology that you need to connect to each other. And the systems that helped hospitals connect and doctors, the train didn't come this far to us. It's not going to. So we have to really figure out if we're going to help with discharge from hospital, we need to see what the plan of care is. So you have to sift through this whole big universe of disconnectedness and say, well, we really don't need their life story. We need the plan of care. And that's where technology needs to move and say, what do we build that is really only this, where everyone who has permission will have to wade through the federal privacy laws and HIPAA, which we can do. But everybody needs to see the plan of care, and everybody needs to provide input. Because if we sell it to someone, because we can help with diabetes, then when we have someone complete a prevention program, we want to add that to the plan of care so the doctor knows when the A1C comes down, maybe we helped. So the plan of care will be the infrastructure thing. The other infrastructure challenge is related to function. That in electronic medical records, they don't track that. So once we sort of like hit it out of the park on falls prevention, we need the electronic medical record to rock that down. The person is a fall risk. This person is incontinent. This person cannot transfer anymore. Any of these things that we measure for function are not in electronic health record. And we need them to be, because this is sort of the glue that starts to make it all work and bring it all together. The other one, which I've learned about actually more since I left Washington and started working with a healthcare consulting company in Kansas City, something that I failed to appreciate was not how hard it is to change people's minds. That's hard. But to change the pattern of their work, the workflow. The workflow in a doctor's office is driven by whatever payment system we put in place, and we can judge how we feel about that. But it is connected to the work they need to produce and the way they need to get paid. And that's how it flows. So we could do all of this other stuff perfectly. Get a contract, we're going to help. And then what you need to have happen is you need to have a doctor go into a patient's room, see them, leave, and go, that's the person I'm supposed to refer. How do we make that happen? Because what you find all over the country with all of this innovation is that the volume doesn't flow. The people, well, the light bulbs are on, but until you can get to changes in work patterns, who makes the call? It won't happen. And this, of all of the other things, has become a real burden for community organizations. Because you don't have to be a financial whiz to know we're doing something new. We need enough volume to cover our costs. And some of those costs will be fixed. I had to buy a computer. And some will be variable. I had to buy a person. But until we can change within the healthcare system and doctors' offices and structures, the pattern of the flow of work, that at some point becomes the ultimate enemy. And there are some people around the country who are the leaders in the field, the people who really have taught me a lot, Jayla a lot, Sherry a lot, who still struggle with getting the workflow to happen. So that's my last one. Okay, are you tired? Your strategic planning documents talk a lot about workforce. It is one of the more daunting issues. And it talks about the demographics. And I don't remember data, but I read this last night, so I do. That by 2040, here in Boulder County, this age wave, and we're not using silver tsunami, right? Have we stopped that because it's completely ageist? Like, older people are not a natural disaster? So don't use silver tsunami. People use silver tsunami because they like how it sounds. It's fun to say, alliteration, silver tsunami. It's fun to say. It's terrible imagery. It's a natural disaster. So in the report, it shows that by 2040 here in Boulder County, you will kind of hit the peak. This age wave, which is my preferred language because you can actually surf a wave. You have to take a wave seriously too, but you'll get by 2040 to that level. And then it doesn't go back down. It stays. Because everybody else is going to get older too. And the people who are going to get oldest, the fastest, are people over the age 80, which here in this county, by that time, will be 244% higher. So, who's going to do all of this work? We could call the state of Maine because they're first. The state of Maine is the oldest country in the nation, and they are struggling. The New York Times had an article this fall about them. They're struggling to figure out where to find enough people to provide care. And that goes from volunteer caregivers to paid caregivers to people who provide attendant in-home care to people at the nursing home to people at the hospital and doctor's office. We need more care. And I think that is a daunting proposition. But I think my silver lining in that is that these divisions that have existed between all of these systems, when faced with that, are a luxury. That instead of fighting over the definitions of case management, we're going to say, you can do case management? Good. Here's 100 people who need the help. That at some point, building these relationships is worth it, and at some point, we will all turn and face the common challenge of providing care and support and supporting health and wellness for a much older population. And it will take all of us. So I think all of these conversations are absolutely worth it now, and it is not a linear progression. Discharge planning has proven that. Not paying for community health workers is proving that. But look in the future. And I always think if you're working on anything, negotiating like Christmas, it's easier to negotiate over next year than this year. That the further out you get, the more you can negotiate because the less threatening it is currently. So I want to go back to the first question that I got when I was assistant secretary. When will people pay us for what we know? Well, we know stuff that's worth stuff. We know things that we can monetize, and we have to keep pursuing those. But I am the biggest cheerleader in the planet on what we deliver. And I think the greatest opportunity in all of these innovations and opportunities is simply the quality I think we can deliver in the community, our ability to improve life and health. And I think in the future, that will be the measurement. And it won't matter who's doing it. I don't care if the nurse works for the Area Agency on Aging or the doctor's office or the health plan. Is the nurse good? I don't care if the system's a for-profit system or a nonprofit system. Do they do good work? And that almost everything I have been working on in the last 10 years is to say back to the Aging Network, you can do it, you're worth it, and we're better than anyone else, we can compete. And we have to position ourselves because it will be quality at some point that will drive all of the financial conversations, all of the flow of money, and the opportunities we all will get to do the work. And it will take all of us together, but I'm absolutely convinced somehow we will survive the age wave and all grow old. We're all going to grow old together. I agree with you. Thank you all for your attention this morning.